bridge therapy and in STEMI. As we all know that cangrelor is a very intravenous P2Y2 receptor antagonist, is in a reversible binding capacity on the platelet receptors, and it has got a rapid onset of action and rapid offset of action with a short half-life, as a beneficial clinical benefits in certain clinical conditions. Cangrelor was approved on the basis of superior efficacy over the other antiplatelet drugs, especially when the clopidogrel has gotten a resistant to certain patients. Cangrelor is only the intravenous P2Y2 receptor is available for the use in acute coronary syndromes. Cangrelor can be equal to the antithrombotic effect as seen in glycoprotein 2 inhibitors, but with less bleeding complications. After administration of IV, 30 micrograms per bolus per kg body weight, followed by the infusion of the 4 micrograms per infusion, concentration of the cangrelor achieved within 2 minutes and has got a very good antiplatelet effects, and the action can wear off within 60 minutes after stopping of the drug. In STEMI, as we all know that antiplatelet drugs are very important. It plays in a very important role, and STEMI and PCA is shown that in a survival benefit and low rate of complications and bleeding complications. And a fraction of patients requires on a PCA, not all the patients requires in a PCA, but a fraction of patients can require to undergo surgical this. And when you loaded with these patients with an antiplatelets, you have to wait for a 5 to 7 days duration before you subject them surgery, especially patients with a left main disease and a triple vessel disease, and patients who are hemodynamically unstable after the PCA or during the PCA, or those who had failed PCA. These are the patients where you want to subject for them surgery, then you will have a difficulty in immediately doing after loading dose of P2Y2 receptors, especially the thiopyridine and non-thiopyridine groups except cangrelor. So it is recommended that all the patients with an acute MI is a dual antiplatelet is must, but the problem is P2Y2 block depends on the patient. It is a P2Y2 receptor is given depending upon the availability and the local scenarios, especially we are going to do the rescue PCA or fibrinolysis or early CABG in case if not given. So what are the limitations? The main limitations of the P2Y2 receptor antagonist is delayed. They will not act within 1 hour. It takes time to act. But immediately you want to take, as you know that in acute MI, the earlier you revascularize is better, but you cannot take immediately these patients after giving the P2Y2 receptors, you have to wait for 1 hour. So in that period, you may lose certain amount of damage to the muscle, or you may not achieve the good antiplatelet effect. So this leads to exposing the high risk, early thrombotic risk, complications, and associated with more effective antiplatelet inhibition and peri-primary percutaneous intervention period. So if you look at this chart, the chart shows that there is drugs, especially clopidogrel, prasugrel, and ticlopidine is commonly used, and ticagrelor, and shows that they all takes more time to act than compared to the cangrelor, which acts within 3 to 6 minutes. So cangrelor, in most of the studies shown that the cangrelor reduces the composite end of death, MI, and ischemic revascularization and thrombosis by 48 hours. Cangrelor can be safe, useful antiplatelet drugs, and especially in patients who are unable to take an oral tablets, especially hemodynamically not suitable patients, like patients who are on shock, intubated, and those patients who are having persistent vomiting, where you cannot give these drugs. So cangrelor plays a very important role in that cases. So CANTIC study also proven that it over the beneficial effect of the ticagrelor using the cangrelor. So meta-analysis of all the studies shown that the cangrelor in terms of death and MI and infected-derived revascularization, stent thrombosis without significant increase in the bleeding risk. So it plays a very important role in acute MI and acute PCS situations. So cangrelor comes as a rescue agent, and because of a potent anti-platelet effect, it is an intravenous agent within 3 to 6 minutes and offset within 30 to 60 minutes. As a rapid onset and provides important beneficial over the ticagrelor and prasugrel. The above two drugs requires a loading day. Some of the times it may have a platelet overreactivity, so they may takes time to act. So transition with cangrelor, when you want to give a transistor, initially giving the cangrelor, after that thiopyridines you have to give after the stoppage of the cangrelor, whereas ticagrelor can be given along with the cangrelor when you want to switch over to the later on for P2Y2 receptor blocker. So as a bridge therapy, several trials have shown that Canglor can be used as a patient waiting for a cardiac surgery. It has maintained a higher rate of maintenance of the platelet inhibition with a significant reduction in the rate of ischemic events and and including the stent thrombosis without increasing the bleeding risk. So it is a rapid reversal of Canglor has also made this a suitable drug for bridging the patient therapy before the surgery who requires a P2Y inhibition. So bridge trial is clearly shown that overall this study showed the sustained antiplatelet effect and during the Canglor infusion and rapid return to baseline function within 6 hours of the treatment after discontinuation during surgery. So take-home message is antiplatelet therapy is a very important role in the PCI, and most of the patient requires a dual antiplatelet therapy. When P2Y2 receptors are given, you have to wait for 5 days prior to sending them the surgery. And Canglor is a drug which has got a rapid onset of action and a fast and offset of action, and it comes as a handy in patients who are waiting for the surgery, especially complex angiography patients. So the use of Canglor is a second antiplatelet prevents a delay in surgery, and there is no periprocedural ischemic events or even bleeding complications. So this highlights the Canglor as a bridge facilitator to CABG without any oral P2Y2 receptor antagonist, even in patients treated with a stent for the infarct-related artery. So this reduces the risk of thrombotic events after the cessation of the other antiplatelet drugs, and also in surgery the patients have been implanted in the regulating stents. So even if you compare to the GP2 receptor inhibitors, the Canglor has got less bleeding complications than compared to GPI inhibitors, but GPI inhibitors there is no documented studies. So in conclusion, STEMI patients and patients who are waiting for the surgery, Canglor has a potential to substitute oral P2Y inhibitors with an advantage of quick antiplatelet effect and reversal of platelet inhibitory effect. Thank you.